All right. Good afternoon, all dear students. Good afternoon, students. So I'm going to do some introduction into ERPM exam. Can all of you all hear me? Everything okay? Yeah, thank you. So just to introduce myself, I'm Dr. Lalindra. I think most of you all know me. I'm a consultant physician and specialist in internal medicine, and also I'm an examiner for final MBBS exam for the last 10 to 12 years. And also, I was an ERPM examiner, but I don't do ERP. I don't go for the ERPM exams anymore because it's because of conflict of interest, like because I conduct classes. But I know the exam format and exam questions and all that in and out because all my friends only are the examiners, my colleagues. But I'm currently also I'm going as a final BBS examiner for all the exams in Sri Lanka also, and I was also a final BBS examiner in Australia, Flinders University, because the Peradini exams I'll be a examiner and Miami University also have an exam. So just to let you know about the ERPM exam. So ERPM exam, like you know, I mean, most of the examiners, most of the teachers would have spoken to you. The part one and part two component, there are a few changes that they have done in the recent past. I could not update you all. One thing, like I could not come and do freely lectures like this before. I mean, I was doing until 2000, I think 23 we did, but after that I could like for about 1 year I could not do because of severe professional commitments, very heavy professional commitments. Because when I was in Puliyapite, I was very busy. But still, we did clinical classes for students, those who came to Puliyapite Hospital, and all those students have passed the clinical component. Those who joined our clinical classes, ward classes in Kulebdi Hospital. There I was super busy, so that's why I could not do that much of classes. But now I have moved to Nigambo General Hospital as consultant physician, and I have little more free time. Uh, so I think we can do more classes, more lectures, more interactive sessions. Because what we mainly need to do is interactive session because the lessons are uploaded to study research. So like I mean the theory won't change and the clinicals won't change because so in say maybe 100 years before the cardiovascular system examination that you did, that's going to be valid for next 100 years also. Like so cardiovascular examination, respiratory system examination, abdominal examination, nervous system examination, that never changes. And the clinical cases, so the diseases 100 years before we had and 100 years after we are going to have, they're also same. Like the common cases that we ask in the exam, say like if you take mitral stenosis, mitral regurgitation, 1,000 years before also same mitral stenosis. So examination, the diagnosis, all those are same. Long cases, history taking skills, they won't change. So even for the next 100 years, it will be the same history taking skills. So that's why, like I mean, the things that we have uploaded to study research, they are really up to date. The long cases, short cases, they need not be updated. But theory sometimes we have to do changes. The reason is because they keep changing the exam format. So in according to that, we will be doing little changes in theory as well, but just targeted for the exam. So I'll let you know how this ERPM exam works with the new changes in the curriculum also. Um, so, so, yeah, so technical problem, just give me a second. Correct. Okay. So yeah, those are my qualifications. I think almost all of you all know the qualifications and all that, right? Okay. So theory component in the ERPM part one. Yeah, the theory component, I'll go through that very quickly because there are some new students as well. They also need to know the new format of the exam. So there will be three papers. I think most of the teachers would have enlightened you on this. So theory component, ERPM part one. So there are 1, 2, 3 papers. Like the medicine paper is combined with the pediatric paper. But whatever it is, it's the same old format. Why do I say like that? Old format also you got medicine 25 MCQs, which is in the true and false format, and old format also you got the 25 single best answer questions, right? So true and false, they are given negative marks, but those negative for a wrong answer, for a positive answer, correct answer, you get a positive mark. So the negative marks won't be carried forward for the next question, right? So it's the same old format. So remember, theory wise, no change when you take the component of the exam, like
Excuse
so
me.
early also 25 true and false MCQs. Uh,
Sir, we can't see the slides.
ah,
Earlier it was visible, sir, but right now we can't see it.
all right, okay, thank you. Now, what about now?
Now we can, sir.
Sorry about that. I'm extremely sorry. Uh, so 25 MCQs true and false format, which is like the same old style, same questions, no changes, 25 true and false. Same 25 single best answer questions, but only difference is earlier we had a separate medicine paper. Now we have medicine and pediatric combined paper, right? So, but what I would suggest is, like, medicine is a subject, it's difficult, but it's a scoreable, like it's a subject where you can score marks. So, medicine paper try to score about 55. And our target is for that. Our target is not just to get 50. Our target is always to get single best answer questions about 60% and true and false about 50%. So that you go up to about 55%. So even if you get a difficult pediatric paper, you can compensate for it because overall you will get the 50%, right? So medicine is the target. Medicine paper somehow try to achieve this 55 goal. So that is what we are aiming for, right? Okay. So theory, no changes, same old theory with 25 MCQs, 25 SP. So we are going to do, a lot of classes for that. We have uploaded all that presentations. I'll be updating some of the questions because, and also the new questions, the new question papers like the 2024 final MBBS, 2024 KDU papers, and 2024 ERPM question papers. And also we have like targeted question papers which are discussed in the final in the local medical schools targeting the final MBBS exams, and also those we will be discussing in the due course for the theory in the upcoming exams in 2025. Then also I'll be giving targeted question papers like that I have done in the past also, and I'll be doing in the future also targeted question papers. So like just targeting the like it's ad hoc, like just targeting the next available exam. We'll be giving some targeted papers. Like you can ask your senior students how many students were benefited from that targeted question papers. So there were lots of questions from our papers. Some students used to say, "Sir, just like it was just like another class given by you, we got questions like that." You don't have to believe me, but you can ask your senior students, right? Okay, so just to give you to refresh yourselves, I thought I'll discuss few single best answer questions. You also can have a go, like you also can have a try. Let's see some of them. Right. So the first question, a 56-year-old female. So I have another separate format for the single distance questions. That is, this is the world accepted format. That is now, say, for example, actually our country is the country where only you have true and false type questions. Because when you take UK, Australia, USA, Canada, all those countries, they adapt to the single best answer or extended matching question type format. So true and false is a very old format type of questions. But the better world, I mean the better world or the new world, they go for single best answer type questions. So we have done these single best answer questions as students, as registrars in the MRCP format as well as MD format. So the rule is First, you glance through the answers. What do you mean by glance through answers? Or you just scan the answers. So quickly, you just scan the answers. So MRI, so what are the answers here? Five answers: MRI, brain serum, cortisol, TSH, serum, vitamin D, prolactin. So you have some idea. Okay, brain something, cortisol, TSH, vitamin D, prolactin. Just get that idea. You're not going to memorize these answers. You just scan the answer. Just glance through. It doesn't take even 3 seconds, right? Only 3 seconds given for that. Just glance through the answers. Now you read the question. 50. The advantage of that is, once you glance through the answers, you have some idea regarding what they're asking for. They are talking about thyroid diseases, they are talking about vitamin D, they are talking about prolactin level, they are talking about some brain problem, they are talking about so a lot of hormonal problems here, right? And also about brain function. So that thought has gone to your, I mean, this won't happen in one day. This is the very first day that you are doing single best answer medicine question. But as you do the questions with our practice question papers, then this will automatically come to yourself. This scanning through the answers, glance through the answers, then go and read the question. So now let's read the question. 56-year-old female complained of increasing forgetfulness for few months. So this middle-aged lady complaining of increasing forgetfulness or dementia. Also, she was more, so keywords you need to underline. So underline forgetfulness. Also, she was more drowsy. Underline that also, drowsy. And further complains that she had gained weight and alopecia. So underline all those keywords. So what are the, so my dear students, you need to understand what are called keywords in a question. So what are the keywords? Forgetfulness, drowsy, weight gain, and also alopecia. Right. What investigation should be done next? So middle-aged woman coming with dementia and also complaining of alopecia, obesity, and also she's getting more drowsy. What are these symptoms, guys? These symptoms you also can get with anemia, but more important than that, you get this with, yes, hypothyroidism. It's a classical symptoms of clinical hypothyroidism. Why? So, what is the clue, guys? The clue, the most important word here is alopecia. So, what is alopecia? Loss of hair. When a patient complains of alopecia, right? Uh, Only few things should come to your across your brain. So whenever you have a patient with alopecia, the first thing that we investigate is whether the patient has got hypothyroidism. We as clinicians, we first do a TSH level to see whether the patient has got hypothyroidism. So alopecia is a key word here, and also she's gaining weight and she's drowsy. So what will be their complaint? They will say, Dr. මට නිතරම නිදිමතයි, කම්මැලි, වැඩක් කරන්න හිතෙන්නේ නැහැ. හැමතිස්සෙම නිදා ගන්න හිතෙන්නේ. කන්නත් බෑ, හැබැයි මාව මහත් වෙනවා. ඇඟ පුරව දානවා. කකුල් දෙක ඉදිමෙනවා. So they complain of ankle edema, facial puffiness, loss of hair, then skin is very dry, lethargic, uh, and also they complain of memory problems like increased forgetfulness, and sometimes they can go into severe dementia as well. So, and also they have cold intolerance. On cold days, they find it very difficult to cope with. If you palpate their pulse, there'll be bradycardia, and also sometimes you can even end up with pericardial effusions and pleural effusions. So those are the problems, and also they get constipation. Right? If it is a young female, they will also complain of menorrhagia, sometimes even subfertility, secondary subfertility. So these are clinical problems that you get with hypothyroidism. So guys, in a single best answer question, there are clinical problems, multiple problems, but keywords, you need to pick them. So middle-aged woman coming with the drowsiness, weight gain, alopecia, that should prompt you to make a diagnosis of hypothyroidism. So if you are suspecting hypothyroidism, what is the first and foremost investigation? The first investigation, you have to do a screening test with TSH, right? And what about if it is hyperthyroidism? If it is hyperthyroidism, the first test is not TSH, but you have to do free T4 and TSH both together. Free T4 and TSH, that is for hyperthyroidism. But hypothyroidism, you only do a TSH. And what are you expecting in the TSH? You expect a high TSH level. Why primary hypothyroidism? No? So your TSH level will be elevated more than 4 units, more than 4 international units, because normal range is 0.42. 4, so it will be more than 4. Why? TSH is elevated. But your free T4 levels, if you check, that will be low. So in hypothyroidism, free T4 levels are low and the TSH level is high. Right? So that is primary hypothyroidism, or what you call Hashimoto's thyroiditis going into primary hypothyroidism. What is the treatment? Treatment is you give lifelong thyroxine. And how do you take thyroxine tablets? You have to take it first thing in the morning as empty stomach. So empty stomach, first thing in the morning, with half a glass of water, and you can't take any meals or tea or anything like that for 1 hour after finishing taking the drug. So you have to keep a gap of 1 hour, right? Right. So good question, isn't it? So the answer is the third one, C, TSH. One might ask, sir, if the patient has got forgetfulness, why don't you do MRI brain? No, guys. The thing is, even if you do MRI brain, like if patient complains of dementia, you can't find anything in the MRI brain unless you do a PET scan or something like that. But still, she's her problems are not only forgetfulness, she has other problems as well. So it's a systemic disorder with some brain involvement, forgetfulness. So therefore, doing MRI brain would not sort out all your problems. Understand? So did you understand the way we approach that question? Yeah. So that's what we need to learn in the due course. Right. There's another single based answer question, just to give you an idea what the single based answer format is. So this format has not changed. Okay. So again, we glance through the answers: Crohn's disease, chronic pancreatitis, irritable bowel syndrome, hyperthyroidism, high, hyperthyroidism has been repeated twice. So Crohn's disease, chronic pancreatitis, irritable bowel syndrome, hyperthyroidism. As the fifth one, can you please write, um, yeah, rectal carcinoma? Rectal carcinoma, fifth one. Sorry about that, like pretty mistake. As the fifth one, you write rectal carcinoma or bowel cancer. Right. So, guys, when you read this, when you glance through the answers, what is the thing which crosses your mind? So, there's Crohn's disease, chronic pancreatitis, irritable bowel syndrome, hypothyroidism, and bowel cancer. All the five answers are linked with something to do with the GI tract, isn't it? Like maybe some chronic diarrhea-like problem, because there's this Crohn's disease, the chronic pancreatitis that causes chronic diarrhea, irritable bowel syndrome causes chronic diarrhea, then hypothyroidism causes chronic diarrhea, and then bowel carcinoma also can cause diarrhea, sometimes constipation. It can even alternate. Right? If it is bowel cancer, what type of diarrhea? Diarrhea mixed with blood, isn't it? And they can complain of altered bowel habits as well in bowel carcinoma. Right. So your mind is focused now. You know it's something to do with the GI tract diarrhea. Let's read the question now. 35-year-old woman presented with night blindness. So young woman coming with young woman coming with night blindness. Very significant, isn't it? Night blindness. What do you mean by night blindness? That is with the sunset, like so it will be like what happened is like when it becomes a little bit dark, people are unable to visualize things. So I mean, in old age it can happen naturally, but in young age it's very unusual. So what thought crosses your mind? If a patient complains of night blindness, you must think whether that patient has got vitamin A deficiency. Vitamin A deficiency, right? So also ecchymotic patches and easy bruising. So ecchymotic patches and easy bruising. Why do you get easy bruising and ecchymotic patches? Then what is ecchymotic patch? That means bluish discoloration of your skin, as if someone has damaged your skin or muscles. So ecchymotic patches, bluish patches. That's due to bleeding. Then also easy bruising. Easy bruising means like even with minimum trauma, like maybe when you touch a chair or when you touch a table, you get some bluish patches in your skin. Easy bruising. Why do you get this? Two problems. One is platelet dysfunction, like if you have thrombocytopenia, low platelets, it can cause it. Also, clotting factor deficiencies can cause this. So it's a clotting problem, blood clotting problem that can cause easy bruising and also ecchymotic patches, either due to a clotting problem, clotting defect, or due to platelet count problem or platelet functional problem. Then also patient, so keywords here, so bleeding, you can encircle both and write bleed in there. Then night blindness. Then other keyword is the most important word here, the most important statement in this question is chronic diarrhea. So patient also got chronic diarrhea. That's the starting. Always I have been teaching medical students, like in the single base transmission, there's a starting point or the catch. The catch is chronic diarrhea. Because we read the answers were also on diarrheal problem. So chronic diarrhea. So it's not acute diarrhea, chronic. That means the diarrhea has been going on for more than uh, 8 weeks. Yeah. She fell in the washroom and got a college fracture as well. So young girl to fall and get a college fracture is or with a deformity. What is college fracture? Due to fracture of the radius. Here, when you fall like this, you can break your the wrist bone, the radius. And then you get what is called deformity. In surgery, you would have learned that it is called Colles fracture. So only when you have very weak bones, you can end up with Colles fracture. So why do you get very weak bones in a young woman? Maybe either due to osteoporosis or maybe due to severe osteomalacia. That's due to hypocalcemia. Either due to osteoporosis or due to osteomalacia from hypocalcemia. What is the most probable diagnosis? So, guys, now we have read the answers. So, what are the key words here? One is chronic diarrhea, one is night blindness, vitamin D deficiency, then there's bleeding, and also there is. So, you have to write down these things. So, actually, I write down these things and I link and show you, but today I'm not going to do that because it's just an introductory session. But if you go through my videos, like while I'm teaching, I'm drawing these things and showing you on how to link these things and arrive at the best answer. So that's really mind focusing. Vitamin A deficiency, easy bruise that's due to clotting problem, chronic diarrhea, and then calcium deficiency. So vitamin A, calcium, clotting problem, and a chronic diarrhea. So how can chronic diarrhea cause all these problems? Vitamin A deficiency, calcium deficiency. Why calcium deficiency? So now you are going to think, can chronic diarrhea cause calcium deficiency? Yes, if you have got vitamin D deficiency also. Vitamin D deficiency can cause low calcium. Then why this easy bruising, clotting problem? That is due to maybe vitamin K deficiency. Vitamin K deficiency has caused impaired clotting factors, impaired production of clotting factors. There are vitamin K dependent clotting factors. Factor 2, 7, 9, 10. Right. So guys, this is a patient who has got chronic diarrhea with vitamin K deficiency, vitamin A deficiency, and vitamin D deficiency. So what is the most likely diagnosis of yeah? So chronic diarrhea. Why patient has got vitamin D deficiency? Why patient has got vitamin K deficiency? Why patient has got vitamin D? What is common with these three vitamins? Vitamin A, D, K. They are lipid soluble vitamins. What are they? They are lipid soluble vitamins. That means if a patient has got some problem with lipid digestion, say, for example, a patient has got lipase deficiency. Lipase deficiency. Lipase is a pancreatic enzyme. There are exocrine pancreatic enzymes like lipases and amylases and tryptases. So lipase for lipids, amylase for carbohydrates, tryptase for proteins. Then patients have got like when you get pancreatic deficiency, you also can get endocrine pancreatic insufficiency where you end up with lack of insulin, ending up with diabetes. But exocrine pancreas, that means outer pancreas enzymes are these amylase, lipase, and tryptases. So due to lipase deficiency, you can get lipid maldigestion, reduced digestion, and reduced absorption, causing a lipid deficiency, and that causes what is called steatorrhea. Have you heard of this term? Steatorrhea? That is, you have stools, bulky stools with a lot of fat in it. Why? Fat is not digested. Fat is not digested. So fat is passing with stools. So it's very bulky and very smelly due to fat, very smelly, difficult to flush in the lavatory, difficult to flush in the toilet. So that is called steatorrhea. It's like clay colored stools. So that's due to lipid deficiency. And so due to this lipid deficiency, lipid soluble vitamins are also deficient. Vitamin A, D, K. So so the most likely answer is a pancreatic insufficiency. The answer is chronic pancreatitis. It's not an easy question. It's a difficult question, but it's a true ERPM and also finally BBS single best answer question. So I want to show you easy question like the one that we did before, and also difficult question like what just we did now. So here you need to have a lot of theory and understanding. So in our GI lectures, we have taught all these things. We have talked about chronic pancreatitis. We have done these questions also in the revision papers. In theory, I have taught you about the gastroenterology module. I have taught you about how chronic pancreatitis affect your lipase deficiency, chronic pancreatitis, how you get lipase deficiency and ending up with chronic diarrhea and lipid soluble vitamin deficiencies. Right? Okay. So the answer is chronic pancreatitis. What is the commonest cause of chronic pancreatitis? Yes, heavy alcohol consumption. But this is a young girl. What do you think? Anyone? Any thought other than alcohol?
Gallbladder stone.
Good, but very good answer. But gallstones usually cause acute pancreatitis. Can you remember the mnemonic? Get smashed. Acute pancreatitis, you have to remember the mnemonic called get smashed. You can Google that and see. So gallstones, E is for ethanol, like that, get smashed. Right? So here, young women, if they get chronic pancreatitis, you must think of autoimmune diseases, autoimmune pancreatitis, autoimmune pancreatitis. It's a difficult question. Right? So it's not Crohn's disease. Why? If Crohn's disease, you get chronic diarrhea, but you don't get this easy bruising and blind blindness and things like that. Then it's not irritable bowel syndrome. In irritable bowel syndrome, it's a benign condition. It's due to your stress and anxiety and depression. You get alternating bowel, like you get alternating diarrhea with constipation, and also they have abdominal pain, which is relieved with defecation. It can't be hyperthyroidism because in the hyperthyroidism you have other set of clinical features like increased sweating, tachycardia, things like that as well. And in hyperthyroidism causing chronic diarrhea, you do get this easy bruising, night blindness, vitamin D deficiency, things like that. And bowel cancer, there's classical history like in bowel cancer, you get this diarrhea mixed with blood, and you will have loss of weight, loss of appetite, things like that. So answer is the third one. Sorry, answer is the second one. B, chronic pancreatitis. Now we are going to, so that's the single best answer type of questions. So single best answer type of questions, there are no negative marks. For a correct answer, you get the full marks. So our target is, guys, in the single best answer paper, the 20 out of 25 questions. That's what I have been targeting. That's where I am training my students to achieve this goal. What is the goal in single best answer questions? We need to score, we need to get at least 18 questions correct, at least 18 questions correct in single best answer format. That's very useful. Why? Usually the true and false format, even the best students get somewhere around 50%, even the best student. Usually students compensate from the single best answer question format. So our target, like as you do a paper, like right now at the beginning when you do a question, your single best answer mark may be just 10 and 11 correct out of 25. But we gradually, you can also see this how we gradually mold you to that target. And finally, when they do a paper, they get about 80-20, like most of the students, they get 20 plus correct out of 25. And that is the target. Then it's very easy to get a 50 more than 50% mark in the final final medicine paper, because you can compensate for the MCQ format as well. So I'm just now going to give you some understanding briefly about what is called true and false type of question format. So let's do two questions on true and false. Regarding, so that you read the question first. Regarding
Sir,
yeah,
sir, may I ask a question about the previous question?
yes,
The Crohn's disease, that question.
yeah.
Sir, if the terminal ileum is inflamed in Crohn's disease, that can cause vitamin A deficiency, vitamin D deficiency, and all those features which are also in chronic pancreatitis, right?
No. In Crohn's disease, you get a terminal ileal disease. You get inflammation of the terminal ileum. So terminal ileum, what are the substances which have been absorbed? Albumin, calcium. Then you get absorption of bile. You also get absorption of vitamin B12. So when you get Crohn's disease, one of those striking features are you get ankle edema. Why do you get ankle edema? Due to lack of albumin. And also, why do you get, and also they complain of numbness of their feet. Why is that? Due to B12 deficiency. Because in Crohn's disease, the common area, like the area affected is terminal ileum, and terminal ileum is the place where you get absorption of vitamin B12. You can get calcium deficiency, but remember, calcium is also being absorbed in the jejunum, in addition to terminal ileum. So in Crohn's disease, the pitch is quite different to this one. Understood? Yeah.
Okay, sir.
Yeah, thank you. So regarding Guillain-Barré syndrome, presence of a sensory level is a characteristic feature. Now, guys, when you do the true and false paper, you need to understand few words. Words like characteristic, recognized, pathognomonic. You can write down also these words. One is characteristic, one under the other, characteristic. Then the other word is recognized. Then the other one is seen in, seen in. Then the other word is pathognomonic. Then the other word is diagnostic. Then the other word is suggest the diagnosis or suggestive. Suggestive or suggest the diagnosis. Guys, in the true and false paper, we most of the time we make errors, we make mistakes due to these 6 or 7 English words that I told you. These English words, they are not medicine words, they are English words. These are the words which make it wrong for most of the students. So what is characteristic? Characteristic means those are one of the characters of a certain disease. See, chronic diarrhea is characteristic of Crohn's disease. Chronic diarrhea is characteristic of chronic pancreatitis. Chronic diarrhea is characteristic of irritable bowel syndrome. So, did you understand? It's a one character of that particular disease. Now, I am going to say, uh, I'm going to say, see, let's say, yeah. So I told you about, yeah. So if I say chronic diarrhea is recognized in Crohn's disease, is that correct? Yes. All the characteristic features are also recognized. All the characteristic features are also seen in, right? So chronic diarrhea is seen in Crohn's disease. Chronic diarrhea is seen in chronic pancreatitis. Chronic diarrhea is recognized in Crohn's disease. Chronic diarrhea is recognized in chronic pancreatitis. You got my point. So all the words which come under characteristic are also recognized, are also can be taken as seen in. Did you understand that point? No? It's very important, guys. Huh? It's very important to understand. But all the words which are coming under recognized are not characteristic. Right? Now, say for example, I'll give you an example. Now, Crohn's disease, very occasionally, very rarely, right? Crohn's disease usually doesn't cause blood-stained diarrhea. Which causes blood-stained diarrhea? Characteristically, ulcerative colitis. So we'll say like this. Now listen to me very carefully because guys, this is the place where students lose marks. Otherwise, MCQ is a very easy thing to. They give the answers also. You have to say when it's true and false only, not like single best. But still, majority of students score, like even the best students scores only about 50. Right? Nothing more than that. We have analyzed these papers for donkeys years. Right. Now, I'm going to say Bloodstain diarrhea, right? Remember this, bloodstain diarrhea is characteristic of ulcerative colitis. True or false? Cool, you all are not answering. Very correct. Why? Bloodstain diarrhea is characteristic of ulcerative colitis. Then bloodstain diarrhea is recognized of ulcerative colitis. Again, true. Correct? Right. Now, I'm going to say, listen to me carefully. Bloodstain diarrhea is recognized in, oh no, bloodstain diarrhea is characteristic of Crohn's disease. True or false? False. Bloodstain diarrhea is not characteristic of Crohn's disease. It's not a character of Crohn's disease. Then I'm going to say bloodstain diarrhea is recognized in Crohn's disease. Yes, that is true. Very rarely, Crohn's disease can cause bloodstain diarrhea. So, it is not a characteristic feature, but it is recognized. Understood? So, sometimes it may not be characteristic, but it can be recognized like a rare feature. But if it is a characteristic feature, it is always a recognized feature. If it is characteristic, it is always recognized. Understood? Good. These are the difficult ones. So as we do questions only, we get used to these words. Then what do you mean by pathognomonic? Pathognomonic means it is only seen in that particular condition. Say caseating granulomata are histologically pathognomonic of TB. Caseating granulomata are pathognomonic of tuberculosis. True or false? True. Caseating granulomata only seen in tuberculosis. If I say granulomata, I'm deleting the word caseating. Granulomata are pathognomonic of tuberculosis. Wrong. False. Why? Granulomatous disease can be seen in sarcoidosis, it can be seen in Crohn's disease, it can be seen in various other inflammatory conditions like polyarthritis nodosa. So, granulomatous disease can be seen in various other inflammatory disorders as well. But caseating granulomata are only seen in tuberculosis. So, there is pathognomonic of tuberculosis. Did you get that? So pathognomonic features are also characteristic features. Why? It is only that particular disease, no? It is also recognized feature. So if it is pathognomonic, it is characteristic as well as recognized. Now I'm going to give you another example. Fever, this is very important at the beginning. Fever is characteristic of infective endocarditis. Yes, infective endocarditis, we almost always you have fever. So, like it is a characteristic feature. Now, I'm going to say fever is pathognomonic of infective endocarditis. No fault. There are thousands of diseases where you have fever. It is not pathognomonic. Now, I'm going to say fever suggests a diagnosis of infective endocarditis. Suggestive. Now, chronic cough suggests a diagnosis of tuberculosis. Chronic cough suggests a diagnosis of tuberculosis. Correct. When you have a patient with chronic cough, you have to screen for tuberculosis. When you have a patient with long-standing fever, fever going on for more than 2 weeks, we always do a 2D echo. Why? We are not going to do a 2D echo to see whether the patient has got heart failure. We are going to do a 2D echo to see whether the patient has got infective vegetations. That is infective endocarditis. So, fever suggests a diagnosis of infective endocarditis. Chronic cough suggests a diagnosis of tuberculosis. Understood? Right. But it is not diagnostic. The word diagnostic and pathognomonic are same. The word diagnostic and pathognomonic are same. This is very difficult, guys, right? These few words, but you know, as we do questions, you learn. So even I can get wrong. Even I can make mistakes. So even the examiners, guys, because I am an examiner, so I know when we make questions, sometimes I think of something and make a question, but then another examiner might say, no, Lalindra, I think this is that answer. So sometimes we change, then we give correct or we make the entire question, we just skip that way. That means we give correct mark for all the answers. Right? So there are things like that also happening. Right. Anyway, so regarding Guillain-Barré syndrome, here they are not using any words, just regarding Guillain-Barré Guillain-Barré syndrome, which are true or false. Presence of a sensory level is a characteristic feature. Is that correct? No, wrong. Why? Sensory system is absolutely normal in Guillain-Barré syndrome. Guillain-Barré syndrome is also called acute inflammatory demyelinating polyneuropathy. This is the problem of the peripheral nerve, polyneuropathy, but due to inflammation of which nerves? Motor nerves, not sensory nerves. It's the acute inflammatory demyelinating polyneuropathy of motor nerves. So you can end up with the motor paralysis, where you will have ascending flaccid paralysis. Ascending flaccid. Why flaccid? Low motor neuron type. Low motor neuron type of paralysis. But sensory system is absolutely normal. You may complain of a bit of paresthesia, but sensory system examination is normal. So that is false. Exaggerated tendon reflexes may be present. Is that correct? False. Why? I told you now a little while ago, Guillain-Barré syndrome is a low motor neuron type of paralysis. So if it is low motor neuron type, what do you expect in the tendon reflexes? They should be absent or diminished. Either absent or diminished. Most of the time, they are absent. Exaggerated reflexes are suggestive of what? Upper motor neuron lesion. Exaggerated reflexes are suggestive of upper motor neuron. So where is the upper motor neuron start from? Above the L1 level. What is L1 level? Above the groin. If you take above the groin level, so above this, above L1 level, above the groin level. So that is where the spinal cord ends at. So the place where the spinal cord ends is at L1 level. So all the lesions above the L1 in the spinal cord, they are upper motor neuron type. So if you get a spinal cord lesion, like say for example transverse myelitis or spinal cord compression, then you get bilateral spastic paraparesis. Bilateral spastic paraparesis with bilateral exaggerated reflexes and upgoing plantars for a spinal cord lesion. Bilateral spastic paraparesis with exaggerated reflexes and upgoing plantar, because it's upper motor neuron type. But Guillain-Barré is peripheral nerve. It's not spinal cord. It's the peripheral nerve. So it is low motor neuron type. Therefore, you get loss of reflexes. Understood, guys? See how we approach these questions. I just gave you just two questions just to boost your interest. Dysarthria is not a feature. Dysarthria is not a feature. So why do you get dysarthria? Dysarthria means the difficulty in articulation of words. You get two types of dysarthria, like you can get a low motor neuron type of dysarthria and a spastic dysarthria, what you call upper motor neuron type of dysarthria. Here what you get is low motor neuron type of dysarthria, where you end up with a nasal speech. So that's due to bulbar palsy, bulbar weakness or bulbar palsy. So why bulbar palsy? So when the patient gets Guillain-Barré syndrome, their throat muscles, the pharyngeal muscles, also the muscles of the tongue, muscles of the palate, they will be weak. Why? They are innervated by what are called bulbar nerves. So when the bulbar nerves are paralyzed in Guillain-Barré syndrome, then you get what is called low motor neuron type of bulbar weakness. Lower motor neuron type of bulbar weakness. So they get a nasal speech and they get drooling of saliva from their mouth. So they cannot swallow saliva. They get drooling saliva from the mouth, from the edges of the mouth. Right? And they get dysarthria as well. So dysarthria is a feature, not so if you say not a feature, that is false. The next one, cerebrospinal fluid protein is increased. Very true. So here usually we do the lumbar puncture after the 10th day of the illness, paralysis. After the 10, usually 14, we say after 10 to 14 days of paralysis, weakness, we do the lumbar puncture and examine the CSF, cerebrospinal fluid. What do you notice? The cell count will be nil. Your red cells, the lymphocytes, neutrophils, they will be 0 or maybe just 1. And the protein levels will be very high. The protein level will be very high. So this is given a term called cytoalbuminic or cytoalbumin dissociation or cytoprotein dissociation. It's called cytoprotein. Cyto means cells, other one is protein or albumin. Cytoprotein dissociation. There's a difference. Proteins are very high, but the cells are normal. So what is the difference with the bacterial meningitis? In bacterial meningitis, your proteins are very high, but your cells are also very high. The neutrophil count is also very high in bacterial meningitis. If you write down these things, are important points. If you take tuberculous meningitis, TB meningitis, then their cell count will be high, the neutrophils as well as the lymphocytes. Now, if it is pyogenic meningitis or bacterial meningitis, only the neutrophils will be high. But if it is TB meningitis, the lymphocytes as well as neutrophils both will be elevated, and lymphocytes are higher than the neutrophils. Lymphocytes are higher than the neutrophils, and they also get elevated proteins. Then if you get subarachnoid hemorrhage, there also the CSF proteins are very high, but their main cells are red cells because they have bleeding. So they have red cells, and that gives a yellow supernatant also, and their protein level is also high, right? So here the cells are negative, but the protein levels are very high. That's called cytoprotein dissociation. So steroids improve the prognosis. Wrong. In Guillain-Barré syndrome, steroids have no place in the management. That's false. Question number 2. Regarding Addison's disease. What is Addison's disease, or what you call primary adrenal insufficiency? Addison's disease is also called primary adrenal insufficiency. Primary adrenal insufficiency. So why do you get Addison's disease? That's due to autoimmune destruction of the adrenal gland, which is the suprarenal gland. Autoimmune destruction. So you develop autoantibodies against your own adrenal gland. Autoantibodies. Right? So they will go and damage the adrenal cortical cells, and your production of cortisol, glucocorticoids, cortisol, as well as the mineralocorticoid will be deficient. So they will have mainly cortisol deficiency. So cortisol is a life essential hormone, and when you have lack of cortisol, you get hypotension, you get lethargy, frequent abdominal pains. I mean, how you get abdominal pains is not explainable, but you get that as a clinical feature, recognized clinical feature. You get severe dehydration. You get frequent hypoglycemic episodes. You get hyponatremia, low sodium, hyponatremia, hypoglycemia. The potassium level is little high, so elevated potassium. So sodium is low, potassium is high. Write that down. Low sodium, high potassium, low glucose, and they cause severe dehydration, which cause high blood urea, elevated blood urea. And they also can cause hypotension, low blood pressure, and you can even fall to the ground. Fainting episodes, hypotension. So when there's low production of cortisol, there's there's thing called negative feedback mechanism. So the adrenal gland puts out what is called cortisol. Adrenal gland gets stimulation from ACTH, which is secreted by the anterior pituitary. Anterior pituitary gland secrete a hormone called ACTH, adrenocorticotropic hormone, that positively stimulate the adrenal gland to produce cortisol. So if the cortisol level is low, this negative feedback mechanism get reactivated and your ACTH level will rise. Just like in hypothyroidism, how your TSH level rises. Understood? I told you before. In hypothyroidism, your TSH level rises too. Here also in Addison's disease, your ACTH level will be high. ACTH level will be high, but the cortisol level will be low. And because the ACTH is high, ACTH mimics melanocyte stimulative hormone, MSH. So where do you get melanocytes? In the skin. That's the hormone which gives you the pigmentation. So due to high ACTH levels, there will be increased pigmentation. So increased pigmentation, so they are usually, these people are very dark. They are blackish. So they get increased pigmentation around the eyes, in the buccal mucosa, inside the mouth, buccal mucosa. In the palmar creases, these creases will become very dark in color. Right? So regarding Addison's disease, hyponatremia is characteristic, very correct. It is characteristic feature. hyponatremia and hypoglycemia, they both are characteristic. So write that down, hyponatremia, hyperkalemia, hypotension, hyponatremia, hyperkalemia, and hypoglycemia, and postural hypotension, and pigmentation. They are the most characteristic features. Hyponatremia, hypoglycemia, hyperkalemia, pigmentation, and hypotension. These are the very characteristic features of Addison's disease or adrenal insufficiency. Right. Hyponatremia is characteristic true. Hypertension false. It is hypotension, low blood pressure. Hypoglycemia, true, I told you. Increased skin pigmentation, suggestive, very correct. So if a patient has got skin pigmentation, one of the first and foremost thing that we investigate is doing a serum cortisol level to see whether that is low, suggestive of Addison's disease. So that's correct. Abdominal pain is recognized, very true. I told you in Addison's disease, we really don't know the reasons, but they very commonly complain of abdominal pain and also dehydration. So that is true. So you understand that's how we do the true and false type of questions. So that is the format of the exam, the part one, right? So 25 SBS, 25 MCQs. So even if you make a error or wrong answer, for that wrong answer you get a negative mark. For a correct answer you get a positive 1 mark. So the negative marks won't get carried forward for the next question. Like if you get say 3 answers wrong, so 3 answers wrong means you have got 3 minuses. No? So then you are going to end up with a minus score. But remember, you are not given minus scores. Your minimum would be 0. So you are getting 0 for that question if you have got 3 wrong answers. Right. So that's the theory component. Now the clinical component. Yeah. So clinical component. Just grab some water. Maybe just one. Right. So the clinical component of the RPM exam that has gone through a big change. Actually, that's a needy change, guys. The reason is Sri Lanka, because our medical education has very high standards. So we have to go according to the Western world. Like we are not be like other countries like say when you take countries like Switzerland or Finland or the East European countries or West European countries, their medical education is far behind ours. But when you take countries like Sri Lanka, India, Pakistan, our medical education is quite good because we were the British colonies. So we have the same education like what you get in UK or Australia. That's why when we went work in countries like Australia, UK, they have high regards. And we can easily say, for example, I'm an MRCP examiner as well. I'm going for MRCP exams as well. So like because they recognize us a lot, our clinicians. So that's why I think the medical council decided to change the format of the exam. It is OSCE, objective structured clinical examination, something like that. So OSCE. Now OSCE will be new to you all, but it's not something new to us because we have gone through OSCE from the day we entered the medical school. Like from even the first year medical students, we have gone through this OSCE. So OSCE is just like guys, so it consists of stations. Now your old format of the exam, because I can teach you about OSCEs very well more than anyone else because I have been an OSCE examiner in Sri Lanka as well as I was finally BBS OSCE examiner in Australia, Flinders University, South Australia. I have conducted OSCEs. Yeah, I was one of the examiners. Sri Lanka also we have done that. So OSCE is, there'll be it'll be in a big hall. Like say earlier your old format of the ERPM Part 2 exam, but how we did was we have cubicles. We have 4 cubicles. Then we have say if you take ERPM Part 2 short cases, your cardiovascular 3 cases in one cubicle, respiratory 3 patients in one cubicle, abdominal 3 cases, neuro 3 cases in one cubicle. So you will be given 2 short cases, you do one CVS and then you move to maybe respiratory, maybe you do abdomen and move to neurology like that, right? Uh, so you move along with the examiner, you are walking. So you finish one patient, then with the examiner, you walk to the next station, right? That's what it happened. Or you go to another, you're walking from one patient to another patient. Now, but at long case, you will be given a patient, you spend with the patient, and you start taking the history. So here the difference is now in OSCE, it will be in a big hall, one big hall, not just rooms, not in different rooms. One big hall, maybe a main hall or maybe auditorium or something like that. So in that, there'll be few beds kept for patients, and there'll be few desks kept with a X-ray hung on the wall, the illuminator hung on the wall with the X-ray. Maybe ECG, some ECG strips are pasted on a file and kept on a disk. Or maybe some lab investigation reports, or sometimes arterial blood gas reports kept on the table for you to interpret. And they write down few questions and paste it on the table itself. So the blood gas is kept there and they ask, what is your ABG diagnosis? What is your arterial blood gas diagnosis? What are the common conditions which can cause this type of problems? What is the treatment of this condition? So like that, they can give those are called objective structured clinical assessment, right? That type of questions will be there. So, not only patients. Now, earlier you ERPM critical component, only patients. Long case also a patient, short case also patients. Then emergency viva, then sometimes we give you ECG, sometimes we just uh, verbally ask questions from you. Because I have been an examiner, I can tell all these things. Now, in OSCE, you have, the other material as well, like, say, for example, lab reports, arterial blood gas reports, ECGs, and also sometimes even X-rays. Mainly, they give you chest X-rays in medicine, but sometimes you can be given an abdominal X-ray as well. Right. So, and also you will have some patients as well. So in patients, usually what they will have is history-taking skills. Now, this is the actual format of the MRCP exam also, which is even conducted in Sri Lanka. MRCP clinical component, or what you call PACES. Here they have one station called history-taking skills. So you have a patient. Actually, now in the Western world, we never have patients. Western world, in UK, Australia, maybe just one patient for the entire, like you have 20 stations now with 2 rest stations. For among 20 stations, you have just one true patient with a physical sign. Right? Most of the time they bring actors. Without actors or actresses, they don't have physical signs. No? So they just bring someone else, and we will pay that person. See, for example, in Flinders, I did the peripheral neuropathy. I did the lower limb examination short case, as a OSCE station. So that actor, he complains of numbness in his feet. So the medical students one by one come and examine the patient, and there are a certain set of questions. So we have a marquee scheme checklist. So when he asks those questions, when he does that examination technique, we give a tick for that, and we give a mark for that. And then finally, you give the students uh, final mark, and also there's something called global mark. You give the final mark as well as the global mark. Global mark is how your appearance, or not the appearance, sorry, how your performance, not, I'm sorry, the performance, not the appearance, sorry. Appearance is also part of performance. Performance in front of a patient as a doctor. So how you perform it? Sometimes even those checklist points may be low. So what is the difference between final mark and global mark? Sometimes the final mark may be little low because the checklist things you have not gone through all that. But you have made a diagnosis, your approach is good. I mean, sometimes the student may not have gone through all the steps in the examination, but did a very good examination, even though he has not completed all the steps in the checklist, but came out with a good diagnosis, good plan, everything, and answers examination questions very well, very professional. Then we give what is called a global mark, right? So remember, there are 2 marks that we have to give, right? But it depends from the exam to exam. All right. So history taking skills. So history taking skills is just like your long case. So for the new students, those who are sitting for the new format of the OSCE exam, uh, this is very similar to long case. For the old format of students, because some students are doing the old format of the exam, the normal ERPM clinical stream that we have, then that also being conducted in 2025 as well, because that will have the classical long cases and short case, long case, and the two short cases, one long case and two short cases. So, guys, whether it's the old format of the ERP clinical component or whether it's the new format of the clinical component, both are almost same. But the new format, in addition to the old format, you are going to have few more things like ECG interpretation, X-ray interpretation, lab investigation analysis, arterial blood gas analysis, things like that also can happen. And also sometimes you might be tested on communication skills, right? So I'll go through that. So history taking skills is just like the previous long case, right? So that we have ERPM course for that in the study research, the long cases one with a lot of videos. So history taking skills, whether it's the new format or the old format, both are same. So history taking skills is one important component in your exam, even in the OSCE station, even in the long case of the old format, both are same. Then the examination skills. So for the examination skills, we have the old format, short cases, 2 short cases. Two systems will be given to you to do the examination. In the new format also, you will be tested on examination skills. You will be asked to do a system examination. Remember, sometimes even you will be given a patient without any physical signs in the new format. But old format, of course, we always give a patient with physical signs. But new format also, most of the time, we will bring patients with physical signs. Like, say, for example, for abdominal case, we bring a patient with jaundice, with some palpable hepatomegaly. If a patient for the cardiovascular system, we always try to bring a patient with a murmur. Maybe AST, maybe BST, maybe MR murmur, maybe MS murmur, some murmur. Then for respiratory system, if you are giving either as a OSCE station or as a short case station in the old format, we definitely give you a patient with physical signs, either crepitations or the patient is in marked reduced air entry, or where the patient has got bronchial breathing, all those physical signs. Right? Or, right? So examination skills station in the OSCE format is very similar to the short case examination of the previous all the old format short cases. Then, guys, in the new format, you can have few additional things like communication skills. They can test you on communication skills. They can test you on communication skills. So, what do you mean by communication skills? So, that of course we don't give patients. That will be just a person. Maybe one consultant is sitting there as the patient. So usually a doctor or a consultant will sit as the patient, right? So breaking of bad news. Say now, Mr. Smith, Mr. Simon. Simon has come with some, severe constipation for about 2 months duration. Now he has undergone a colonoscopy, and now the biopsy report has come, and it has come as high-grade bowel carcinoma. So you are going to tell this to, so you tell, so they will paste. Usually they don't communicate now. Even Peradeniya, when we had the final MBBS exam, we usually don't communicate with the student. We write it in a paper, print it in a paper, and paste it on the nearby the patient. So then student has to read that and do the examination, because different examinations might tell different things. That's why. in order to prevent that, to make it a universal exam, to standardize, they print it in a paper and paste it. Right. So they tell uh, uh, so so Simon was diagnosed to have high grade bowel carcinoma. Uh, you are the treating medical officer, or you are the house officer, and Simon and his family members want to know what the result of the test is. How do you communicate? It's a challenging thing because you, as a house officer, you are going to do this. So, because you, as a house officer, you are going to do it, so you need to know how you do it, right? Right. So, there's a way that we will train you, because that when they advertise the new format of this exam, like when they when they can all of you all hear me? Okay, sorry. So once they advertise the new format like OSCE and all that, for the OSCE station, we will be separately doing. So for the like old students, there's no change. It's the long case and two short cases that we have already given in the study reserve. For the new students sitting for the OSCE examination, um, we have the long cases and short cases, the history taking skills and examination skills. But in addition to that, I'll be teaching you separately how to do the communication skills. So one is breaking bad news, the other one is consent for a procedure, how to take the consent for a procedure, then how to take the consent for post-mortem, that is very important, consent for post-mortem. Then also communication skills, they will teach you, or they will test you on like uh, how to deal with a difficult, violent patient. So there's a violent patient in the ward, like who is drugged, and he's behaving in a very unpopular and very embarrassing way, running around the ward and hitting the others. How to deal with a difficult patient, or how to deal with a violent patient. That's also one of the communication skills that they test for. So I'll be dealing with all these things, and how to. Sometimes they will also tell one of your professional colleagues or one of the doctors is taking alcohol and coming to work. So how do you actually? That's of course a MRCP type question, that alcohol, substance abuse in one of your professional colleagues. That of course they will not test at your level, but sometimes they can give that. So that we will be teaching for the new format of the students. Then analytical skills, ECG interpretation, chest X-ray, and also other X-ray, abdominal X-ray interpretation, arterial blood gas analysis, and investigation results interpretation. That also will be separately doing for the new format students, or skill format students. Right. Right. So history taking skills or long case. So I have given just a sample long case. I'll do this very briefly. The history taking skills. So 30. So for the old format students, what happened is the two examiners are listening. They will stand behind you and they will listen how you take the history. And so I have been an examiner. So we stand behind the candidate and we mark the checklist whether you have asked this question, and then we give a final mark, and then finally the global mark. Right. And then the two examiners, they compare marks and see. So if one has given 60 and the other one has given 35, then there's a big difference. So then the two examiners discuss, okay, why you gave 35, why you give 60? And then they come to a conclusion. Like one has told really good, the other one has told really bad, then there should be, some middle point. So they most of the time they try to pass. If that is this case, most of the time two examiners, they agree with the marks and they put marks together. That's I've been there for the last 10, 12 years. So that's how it happens. Right. So let's see, go through a long case, history taking skills. So even the OSCE format, it will be the same because they are anyway the examiners will be there by your side, marking the checklist. 13-year-old mother of 2 kids presenting with worsening shortness of breath and swelling of feet for 1 month duration. So the problems are 1 month duration. What is that? Swelling of feet, that is peripheral edema or ankle edema, and exertional dyspnea, and also dyspnea, worsening shortness of breath. On a background history of diabetes, she also got diabetes and hypertension for 8 years. So this young woman, young mother, has got diabetes and hypertension for long years, 8 years. And now she is coming with dyspnea and edema. So how do you take the history of this patient? So what is the first thing that when you approach a patient, you must first introduce yourself. I have forgotten to mention that, but I want to tell that, right? So first is introduction. So in between you can write introduction. You have to introduce yourself. You smile to the patient. You don't go staring at the patient like any. එහෙම යන්නේ නැහැ. ලෙඩා කියන්න තියෙන දේවල් වලින් භාගයක් කියන්නේ නැහැ ඊට පස්සේ. හිස්ටරි එක භාගයට දෙන්න. Go with a pleasant smile. බක බක ගාලා hina වෙන්නත් එපා. You go with a pleasant smile, right? And tell, I am a finally a medical student. I want to take some, I want to ask few questions from you. Is that okay? Right? Okay. මම අවසන් වසරේ වෛද්‍ය ශිෂ්‍යයෙක් මම ඔයාගේ විස්තර ටිකක් ගන්න ආවේ ගන්න පුළුවන් නේද? Right. That's it. Right? වැඩි කියන්නේ මම මේ අවසන් වසරේ විභාගයට විස්තර ගන්න ආවේ ඔයාලට කමක් නැද්ද කැමති නම් විස්තර දෙන්න පුළුවන්. ඒ විකාර කියවන්න එපා. Anyway, you take the history no. Right? If she says no, I don't want to give any information, finish it. Right? So you tell her, මම අවසන් වසරේ වෛද්‍ය ශිෂ්‍ය මම ඔයාගේ විස්තර ටිකක් ගන්නවා. හරි අම්මා? Right. That's it. So first the basic things like name, age, where she's coming from, place, and whether she's employed or whether she's a housewife, marital status, whether she's married and having kids. Right? Very basic thing. That's the first introductory statement. So that's a must, right? Okay, next one is you ask the presenting complaint and the duration. Now this is very important how you ask the question. You have to ask the patient, මේ පාර ඉස්පිරිතාලට ඇතුල් වෙච්ච ප්‍රධාන ප්‍රශ්නය ප්‍රධාන අමාරුව මොකක්ද? මේ පාර this time. What is the main complaint which brought you to the hospital this time? What is the main complaint which brought you to the hospital this time? මේ පාර ඉස්පිරිතාලට ආව ප්‍රධාන ප්‍රශ්නය නේද ප්‍රධාන කාරණය මොකක්ද? So there's a chief complaint or the presenting complaint, and you have to ask the duration also. For how long you had this problem? So patient says, doctor, I had this shortness of breath and also edema going on for 1 month duration. Then you ask, are there any other problems during the same time? Are there any other problems which felt you bad or which felt you sick along with this admission? What මේ ප්‍රශ්නේ අරෙන්න තවත් අමාරුත් තිබුණාද? ඉස්පිතාලේට එනකොට. ඒව කොච්චර කාලෙත් තිබුණාද? Those are called subsidiary complaints. Right? So patient might say, doctor, මට මුත්‍රා යන්නේගේ ප්‍රශ්නකුත් තියෙනවා. මට හති වැඩක් කරගන්න බෑ හරියට ඒකට අමාරුයි පණ නැති ගතිය. So patient complaints of fatigue, patient complaints of some urinary problems. That's also almost for 1 month duration. Any other any other complaints and duration. Then analysis of presenting problems to make a differential diagnosis of problem list. Analysis of, that is the difficult part. That is what we call history of presenting complaint. So you take a history of the presenting complaint, you analyze the presenting problem, right, along with the systematic review. Now, say for example, you are going to analyze shortness of breath. How are you going to do that? Now, what are the causes of shortness of breath? It can be due to cardiovascular or renal. That is what you call fluid retention. So it can be due to fluid retention. That is, you retain fluid inside the lungs. When you retain fluid inside the lungs, what you call alveolar edema or pulmonary edema, it's water in the lungs. Not pleural effusion, this is water inside, alveolar. Then, due to that, your oxygenation is poor and you feel short of breath. So fluid retention can occur due to 2 reasons. One is due to heart failure, the other one is due to kidney failure. Either heart failure or kidney failure. Then it also can be due to respiratory shortness of breath. Why? If a patient has got asthma or COPD or chronic cough, bronchiectasis, TB, they all can cause cough and wheezing. But they will have wheezing. හතිය අමාරුව තියෙනවද? වාට මේ Hathia, the word Hathia they use for shortness of breath also. Disney also they use Hathia. Wheezing also they use Hathia. Right? So you can ask, Papu, me Sattada. Usma ගන්නකොට ශබ්ද එන සද්ද එනවද රාන් රූම් ගාල සද්ද එනවද why රාන් රූම් වල සද්ද එනවද wheezes give you loud noises හතිය එනකොට සද්ද ගතියක් සද්ද එනවද පපුවේ සහ ඔයාලට දිනු කාලෙක කැස්සක් තිබුණාද you get a chronic cough so that is very important cough, wheezing, and also you can add one more point using of inhalers. What a කැස්ස තියෙනවද? කැස්සත් එක්ක පපුවේ සත්ත්ව ගතියට එන හතිය තියෙනවද? සහ ඔයා උරණ කරල් හරි ගෑස් එකක් හරි පාවිච්චි කරනවද හතියට? උරණ කරල් හරි ගෑස් එකක් හරි පාවිච්චි කරනවද හතියට? What is උරණ කරල් and gas? උරණ කරල් means the DP inhaler, dry powder inhalers. උරණ gas means metered dose inhalers. Right? Anemia. Anemia also can cause shortness of breath. So, what are the anemic symptoms? As for fatigue, blood loss, history of blood transfusion, things like that. Fatigue. පොඩි වැඩක් කරත් මහන්සි ගතිය. විඩාව දැනෙනවා. Fatigue. And also blood loss. Have you had any bleeding from anywhere of your body? Have you passed blood with your stools? Or have you passed any black colored stools? Have you had any cough with hemoptysis? Have you coughed out blood? You can ask like that. Were you given any blood transfusions or iron pills? Were you given any blood transfusions or iron pills? Why? That's to ask about anemia, right? Because those, if the patient is going to say yes for those things, then the answer is like most of the time this is due to anemia, right? So that's how you evaluate a case of shortness of breath. Very scientific evaluation, and that we expect from the student, right? What else? Then also you do a systematic review. So now you have already covered cardiovascular, you have already covered the respiratory system. You asked about cough and wheezing and inhalers. You asked about the hematology, the blood, but you didn't go into details about cardiovascular and renal, which is the most important. So cardiovascular causes of dyspnea. What questions will you ask, guys? Be with me. Number one, you ask whether the patient has got exertional dyspnea. Wow, mahansi වෙනකොට විතරද මේ හතිය එන්නේ රෙස්ට් කරනකොට හතිය නැති වෙලා යනවා now that is different to respiratory dyspnea why respiratory dyspnea or respiratory wheezing even when the patient is resting you will get that wheezing and the respiratory wheezing you mainly get during night time හතිය වැඩිපුරම එන්නේ රැට එනවා නම් ඒක respiratory wheezing you have got my point and also whether you get this shortness of breath only when you exert yourself only when you after some exertion physical exertion වැඩිපුර මහන්සියට වැඩ කරාම විතරද හතිය එන්නේ. So we ask some leading questions. We ask how many steps you can climb in the staircase? How many meters can you walk on a flat surface? Can you walk from your room to the kitchen? Can you walk from your room to the toilet and come back without feeling short of breath? වගේ කාමරේ ඉඳන් toilet එකට ගිහලා ආයෙත් නැවතෙන්න පුළුවන්ද හති වැටෙන්නේ නැතුව? Right? We ask those leading questions. Okay, can you climb stairs? ඔයාලට පඩි පෙළවල් නගින්න පුළුවන්ද? කොච්චරක් පඩි නගින්න පුළුවන්ද? So if the patient doctor පඩි දෙකක්ම නැග ගන්න බෑ හතියනවා that means it's very significant. With minimum exertion you get this. That is what we call NYHA class 3 dyspnea. NYHA class 4 means you get dyspnea even when the patient is resting. Right. Okay. So you have to grade the dyspnea by asking the number of steps you can climb in stairs and the number of meters or whether you so patient meter ගණන් කරන්නේ නෑ you just ask from room to kitchen room to toilet whether he can walk and come back that is exertional dyspnea that's cardio suggests cardiovascular dyspnea then you have to ask about other leading questions for cardiovascular dyspnea orthopnea how do you ask for orthopnea you ask the patient can you lie flat when you lie flat do you feel short of breath and have you increased the number of pillows that you use have you increased the number of pillows ඔයා නිදා ගන්නකොට පාවිච්චි කරන පොට්ට ගන්න වැඩි කරලා තියෙනවද නිදා ගන්නකොට පොට්ට ගන්න වැඩි කරලා තියෙනවද හතියෙල නිසා right that's for orthopnea then also paroxysmal nocturnal dyspnea ඔයා නිදා ගත්තට පස්සේ හති වැඩි වෙලා හුස්ම ගන්න බැරි වෙලා ඇහැරලා තියෙනවද ඇහැරලා ඇඳි නිදාගෙන ඉඳලා ඇඳි වාඩි වෙලා ඉඳලා තියෙනවද so there is paroxysmal nocturnal dyspnea as with the patient is suddenly woken up in the middle of the sleep and was sat on the bed to relieve his dyspnea. That is paroxysmal nocturnal dyspnea. Right. Okay. So that's how you grade dyspnea cardiovascular. But still, even the renal dyspnea due to chronic renal failure, fluid retention also can cause similar things. So how do you differentiate? You have to ask some more leading questions. You ask, have you got any chest pain, chest tightness, and were you ever given any aspirin tablets, or were you given any tablets to keep under the tongue? So if a patient says, I'm taking aspirin, because aspirin getting up, let to matakai. Patient can remember that. Yes, I am taking aspirin tablets. I was given some tablets to keep under the tongue. Then that suggests some angina. That suggests some ischemic heart disease, which is the commonest cause of cardiac failure. Also, you ask, what වෙනමුණත් හෘදයාබාධ හරි හෘදය වස්තුවේ අමාරු තිබිලා තියෙනවද? Have you had any heart diseases? Because sometimes it can be valvular heart disease, not necessarily ischemic heart disease, which can cause cardiac failure and disease. So you have to ask that. Then for the renal part, what are the questions you are going to ask? How is your urine output? Have you got any reduction of your urine output? Have you got frothy urine? Have you got ankle edema, ankle swelling, and also facial edema, facial puffiness? What a mutra යන ප්‍රමාණය අඩුවක් තියෙනවද? මුත්‍රා පොඩ්ඩද යන්නේ බින්දු බින්දු වගේ යන්නේ. මුත්‍රා යනකොට හුඟක් පෙන ගතියට යනවද? පෙන frothy urine පෙන ගතියට යනවද? ඔයාගේ ඇස් දෙක වටේ ඉදිමිලා තියෙනවද? මූණ ඉදිමුණාද? කකුල් දෙකත් ඉදිමුණාද? So usually facial edema is a classical feature, or periorbital edema is a classical feature of renal failure. Then patient might come out, yes doctor, I have this renal problem. මගේ වකුඩු දෙක නරක් වෙලා කිව්වා. දැන් මේ වකුඩු අමාරුවට තමයි මම බෙහෙත් ගන්න. Because patient is a diabetic patient, so maybe long-standing diabetes causing CKD, chronic kidney disease, or even diabetic can cause heart failure as well. So both are possible. But we listen to this candidate's evaluation of the problem. Even being the very experienced consultant like me can't straight away say, like in one brief consultation in my channel practice, in one day I can't say with this heart failure or cardiac failure in all patients. Most of the patients I can tell, but all patients I can't tell. I have to do some investigation to see why patient has got edema, why patient has got shortness of breath. So what about the student then? So from the candidate, ERPM candidate, we are not expecting them to, pinpoint and say these cardiac failure or renal failure. But we want to listen to you, see whether you are a good, knowledgeable student, whether you can analyze problems. That's all what we want. Whether you can perform as a good house officer. Right. Then the systematic review, the system that we did not cover is the gastrointestinal system. You asked about whether you have any diarrhea or vomiting. The locomotor system we did ask whether you have got any, joint diseases, joint problems, joint swelling, that also you can ask. The nervous system, you can ask, have you had any numbness of your feet? Why? For the diabetes, you have to ask them, numbness of your feet or weakness of one side of the body, that also you can ask. So that is systematic review, the balanced questions you have completed. Then you go through the classic, the checklist. What is that? Now for these checklists, guys, we give a mark. So that's why you have to go through all these things. Past medical history with the patient has got diabetes, hypertension, dyslipidemia, chronic kidney disease, any heart diseases, asthma, or any other diseases. Past surgical history, have you gone through any surgeries? Allergic history, you must ask. We give a mark for that, separate mark for that. Do you have any drug or food allergies? What බේත් වලට හරි කෑමකට හරි allergic ගතියක් තියෙනවද? පළු දාලා කසන ගතියක් තියෙනවද? Medication history, are you on any chronic medications? Are you on any Ayurvedic medications? Or are you taking any other pills for any other disease long term? Family history. You have family history because it's a young woman. Family history of kidney diseases. Because this could be a familial nephropathy. So you have to ask family history of any disorders. Family history of any diabetes. Okay. In the social history, what are the important points? You have to ask about the habits, smoking, alcohol, with they are using in the recreational drugs. And in the relevant case, like say for example, if you get a patient with PUO, pyrexia of unknown origin, or a case of jaundice, then you have to ask about the sexual history as well. If the patient has had sexual malpractices like unprotected sexual intercourse with unknown partners, things like that, you will have to ask in the relevant case. Then also you have to ask about the travel history in the relevant case. A patient coming as fever of unknown origin, you have to ask about travel history. exposure to malaria, and various other tropical infections. Then, how diseases affected activities of daily living. ඔයාට තනියෙන් ඔයාගේ වැඩ කටයුතු ටික කරගන්න පුළුවන්ද දැන්? ඒ කියන්නේ මූණ හොදන එක, වැසිකිලි යන එක, කෑම කන එක, ඇඳුම් අඳින එක, ඇඳුම් ගලවන එක තනියෙන් කරගන්න පුළුවන්ද? So those are activities of daily living, the very basic things. When the patient is independent on them, or when the patient needs support of someone else to do them. How disease has affected activities of daily living. Whether the disease has affected the patient's occupation and also earning capacity. That also you need to ask. Whether the patient's earning capacity is lost due to the disease. Or patient is coming with severe shortness of breath. Whether she may be a garment factory worker, where she can't be employed any further. Patient may be a driver. Patient can't do the driving part to earn money now. So when the patient's job is affected due to the disease and when the patient's earning capacity is lost due to the disease, that also you need to. So this is how you take a nice long case history. So let's check. A second. A small technical issue. It's okay. So actually, I just want to show you like the videos we have done. Show it to you. Yeah. Uh, uh, can you see the screen now? Right. So these are some like there are some long cases that so all these long cases that so welcome to ERPM medicine part B and part C. So in part B we have station 1 the long case and then we have station 2 the short cases, 2 short cases. Would you see in the patient? Remember in your ERPM part B station 1 you are not supposed to touch the patient, you are not supposed to examine the patient, that is only station 2. So history taking skills, you can't examine the patients. You can only talk to the patient. Even the old format long case, you are only taking this history from the patient, right? So another independent marking for example, if a diabetic patient came with leg swelling, you have to ask, okay, for how long did you have the leg swelling? Did you have reduced urine output? Did you have any shortness of breath also? Or did you have frothy urine? Like that, you need to ask few questions. So, like that, you have to go through this part in a chronological order. That is history of person. I'm just showing how you take the long case history there. So, like there's several videos are there. I'm not going to go through the whole thing. Like so, went to a GP. GP ordered a blood blood count, maybe full blood count, and she was told her blood is less, so she has low hemoglobin. I mean, the doctor did not say low hemoglobin. Huh? Hemoglobin කියන වචනේ පාවිච්චි කරාද? No. So doctors have told that she doesn't have enough blood. She needs. Sometimes patients can come out with medical terms. If the patient says of a diagnosis, you can use them, right? Not otherwise, right? You have to give the history taking skills. You have to do the history taking skills in patient's words, right? Not in your diagnostic words, right? So like that, I have taken the history. You can go through them. Udah balan? So, right. Okay, so I'll just skip that. So that's how, like, in that manner, I have done so many long cases covering all the systems. Sample videos are there. So, like, cardiovascular system long cases. So even the all the possible long cases, I have listed down all the possible long cases. What we have given in the final MBBS, what we have given in the ERPF exam, and all those possible long cases in the exam, I have covered. I have given sample long cases, how to take history and all that uploaded. There's a note, like nice, beautifully worked out lecture note is there, and also the videos are there. In most of the important cases, the videos I have done uh, for those long cases, right? So all that is there in our study result. You can go through that. Right, back to our theory long case. So yeah, so hello, good afternoon. Yeah, I'm doing a lecture. Can you call me after 1 month? Sorry. So now, so in a long case, you have to make a problem. So examiner might ask, what is your problem list? What are the differential diagnoses? What are the differential diagnoses? Yeah. So what is your problem list? So you must say, my first problem is exertional dyspnea. Orthopnea and paroxysmal nocturnal dyspnea suggestive of fluid retention. Second problem is patient has got reduced urine output with frothy urine, which suggests some renal disorder or kidney failure. Third problem is patient has got poorly controlled diabetes with peripheral neuropathy and retinopathy. Like that, you make a problem list, right? So first problem is dyspnea. Dyspnea with paroxysmal nocturnal dyspnea and orthopnea, suggestive of fluid retention. Second problem is reduced urine output with ankle edema and frothy urine, suggestive of kidney failure. Third problem is poorly controlled diabetes with uh, peripheral neuro with microvascular complications like peripheral neuropathy and retinopathy, like that. So, and she also got another social problem. She has lost her job, and now she has a very poor earning capacity. Like that, you can make your problem list. Hmm. Differential diagnosis. So differential diagnosis about fluid retention, either kidney failure or heart failure. What investigations will you do in this patient? So that's the format of the exam. So actually nowadays, most of the time, we are told not to ask too much about investigations and management. Like if the student present a good history taking skill, and if the student can present a good history and come out with a good problem list and good differential diagnosis list, from that itself they pass the exam, right? Like we briefly asked about investigation management, but even if you don't tell that in a in a very sort of uh, very bright way, it's okay. But still, we will teach you, we will train you how to present those investigations and management plan as well. Right. So investigation, like for glycemic control, you will do the fasting blood sugar, HbA1c levels, and for daily monitoring, you will do the capillary blood sugar levels. Then for evidence of fluid retention, you will do a chest X-ray to see if there's pulmonary edema. Then you will do 2D echo to see if there's any cardiac failure. You will do ECG to see if there's any ischemic changes in the ECG. Then you will do renal functions, like you will do serum creatinine, UFR to see if there's albuminuria. Then you will do creatinine, I told you that. And they also electrolyze to see if there's hyperkalemia. Um, yeah, so like that you plan out your investigation. And also HB, hemoglobin. Why? CKD patients, chronic diabetic patients, they can end up with anemia. So with the patient has got anemia, full blood count. Right. So how do you manage these patients? So my management will link in two directions. One is for the fluid retention. So because the patient has got fluid retention, I will put this patient on fluid restriction, less than 1000 milliliters of intake for the whole day. I will maintain an input-output chart for this patient, monitor urine output. Then also for renal related problems, I will ask the patient to avoid fruits and vegetable intake, uh, and uh, and monitor patient's potassium. If the patient has got hyperkalemia, I will put the patient on potassium binding resins like calbite and avoid all the potassium retaining drugs. Then for the glycemic control, I will see whether this patient is already on metformin. The patient is on metformin, I will omit that, and I will change you to insulin and constantly monitor patient's blood sugar level at least 3 times a day. So like that, you have to talk about the management. I'm just giving you some brief out the brief layout how we need to brief plan how we have to discuss this long case in the true exam. So we have all this huge collection of all possible long cases in our ERPM study result, right? And they all are exam oriented ones. Yeah, so few questions were there, like next one is about the OSCE station examination skills and the old format short cases. So the 4 systems plus the locomotor system that is can be given. So what possible things can be expected in the short cases or in the OSCE exam? So either to examine the cardiovascular system, respiratory system, abdomen, upper limbs. We don't give we ask student to examine the entire neurological system. We ask them to examine either upper limbs or lower limbs, then upper cranial nerves, or lower cranial nerves, or sometimes we tell you to examine motor cranial nerves, the cerebellar system. So they all come under neurology or rheumatological examination of hands. This is the locomotor system. Usually it's hands, not feet. Then yeah, that all that we have given in our study reserve, all the ERPM short cases, all exam oriented. And mind you, like all the possible short cases in the exam, all possible short cases, we have done videos on them. Even sometimes the murmurs, like the sounds of murmurs, bronchial breathing, that we have uploaded in our videos. So, and also how you do the short examination, I have demonstrated in videos. I'll just share with you one video. You have seen the video, right? Yeah. We are going to examine the cranial nerves. Another ERPM Part B Station 2 short case would be examine, the examiner's command would be examine this patient's cranial nerves. So you will be told either examine upper cranial nerves or you will be told either examine lower cranial nerves. So now we are going to examine lower cranial nerves. That is, we're going to start from 7. So 7, 8, 9, 10, 11, 12. Okay, right. So watch me carefully. See here. මම අවසාන වසරේ වෛද්‍ය ශිෂ්‍යෙක් මම ඒවා පොඩ්ඩක් පරීක්ෂා කරලා බලන්නයි හදන්නේ. හරි? හොඳයි. So first you inspect his face. As you see his face, මේව බලන්න මේ පැත්ත. මේකෙන් බලයින් මන් දිහා බලයින්. So as you see his face, you see there's a facial asymmetry. You can see his mouth is deviated and his right side of the face is sort of flat. He's only having eye closure on the left eye. His right eye is not closing at all. Can you notice this, please? He's only blinking his left eye, but he's not blinking his right eye. And you can see his mouth is deviated to the left side. So this is what we call facial asymmetry. Right. So now I'm going to start with seventh cranial nerve. So 7, 8, 9, 10, 11, 12. Right. So first inspection. So you can see there's a facial asymmetry. Right. See, nalala raligasan me mage egli diha balan. So you can see here he's getting wrinkling only on the left side of the forehead, but right side of forehead there's no wrinkling. If you, so uda balan siya me hunda, you can see the wrinkling appears only on the left forehead, but not on the right side. So right side forehead is flattened down. Right. And also you can see that he's blinking only on the left eye, but his right eye he's not blinking. And you saw this. Esteban, did you notice that? That's called Bell sign. I Tasman, there we go. You can see that the cornea is going up. I Parakaran, did you notice that cornea went up? That is called Bell's sign. So this one I cannot open. He can have tight closure of the left eye. But right eye, you can see he cannot close his right eye and right cornea has moved up. So this is classical paralysis of the orbicularis oculi muscle, and he has got Bell's sign, cornea has gone up. So this is classical right-sided low motor neuron facial nerve palsy. And the next thing is you have to look at the nasolabial groove. So you can see the nasolabial groove on the left side is very prominent, nasolabial groove, but on the right side is flattened. So you got a good nasolabial groove on the left side, but nasolabial groove is flat on the right side. And also you can see the mouth is deviated to the, his mouth is dropping on the right side, mouth is deviated to the left side. So there's mouth deviation towards the left side. See here, can you see this? Beautifully seen. So you can see mouth is being drawn towards the strong side, which is the left side. So right side of the face is weak. And tol wahala, katapumban. Wahala katapumban. So you can see this side, air leaks out, but this side is strong. So he also got facial weakness of his cheek muscles on the right side. He cannot blow his mouth. Katapumban tolvali wahala. He can't do that. He air leaks out. So this is a classical lower motor neuron type of seventh nerve palsy on the right-sided low motor neuron type of facial. Yeah. So because of time constraints, I will not play the full video. So like that, so we have done videos of all the systems, upper limbs, lower limbs, upper cranial nerves, lower cranial nerves with classical cases I have shown you all. So that will be very useful for you all. Because students have given so much of comments to pass the exam, now working as interns. Some are already got through the part one, medicine part one as well. They are working as registrars now. So like everyone has been really benefited. Even the final MBBS students are using this. The local medical students, they are going through these videos. They also, and KDU students, they've also highly benefited from this. Right? Okay. And like so many videos like that we have uploaded, and yeah. So not only that, guys, so they all are exam oriented, and how to work out a differential diagnosis by those short cases. What is the how you present that? Because the thing is, sometimes students examine, but they don't know how to present. So even those presentation skills, the presenting format I have uploaded in my videos. So not only that, guys, since I'm in Digambu now, so we also got the help of another register because I can't do it alone because of my professional commitments, because I'm busy. So we are also we were lucky to get hold of a junior medical registrar. So he's helping out for selecting cases and conducting mock exam classes for you all. So myself and that medical registrar, we both will get together and we will conduct clinical cases for you all, and that will be a real revolutionary thing, because the thing is all this time I was doing classes in the hospital, but that's the most useful thing because we see the real true patients. But this is not inferior to that, because we bring down all the physical sign patients with good physical signs for each system, and two of us will become examiners, and we will get you to examine and present in front of us one-to-one case presentations and clinical examinations. We will do that also for the practical exam. So that we will conduct in a place close to Colombo, which is very convenient to you all. So that's going to happen. So that change we are going to do for the upcoming exam. Right? So I think most of you will be really happy with that because you are getting the touch of an examiner because I'll be doing this an examiner and my registrar is also quite experienced. They also have gone through these MD exams. They are also highly experienced. So we both will get together do the classes for this mock exam for you all. Right. Then, guys, other things are interpretation skills. Like I said that some ECGs or X-rays can be pasted on the disk and get you to interpret. I think I have to rush now because it's already gone. Right. Just briefly. So they will show you ECG like this and ask you to interpret on that. Okay. What do you think this ECG is? What's wrong with this ECG? Yeah. Just to test your knowledge. This is not teaching lesson, but just to give you a brief overview of what we are doing or what's the format of the exam. So this here, what you can, how do you interpret this ECG? I have given a separate video on ECG by DC. All the possible ECG diagnoses are given in that ECG by DC tutorial. This is a patient with tachycardia. What type of tachycardia? Is it regular or irregular tachycardia? RR intervals are regular. So it's a regular tachycardia. Then you have to look at the QRS complexes. Are they narrow complex or broad complexes? Narrow complex. You can see QRS is very narrow. Yeah? QRS complexes are very narrow. Just like one line. So this is a narrow complex regular tachycardia. Narrow complex regular tachycardia. And so narrow complex regular tachycardias, two differential diagnoses. One is sinus tachycardia, the other one is SVT or what you call supraventricular tachycardia. How do you differentiate those two? In sinus tachycardia, you can visualize the P waves. You can separately identify the P waves. But here in this ECG, you cannot see the P waves here. Rhythm stream, you cannot visualize P waves, just QRS waves only. So this is a patient with regular narrow complex tachycardia without obvious P waves. Therefore, the diagnosis is SVT. So you can't just say SVT. You have to. So they ask what is the ECG diagnosis. You have to interpret. Then only. So they will ask what are the ECG findings. What are the ECG findings? You say this is a regular narrow complex tachycardia without obvious P waves. Therefore, most likely diagnosis is supraventricular tachycardia. That's how you have to get the final diagnosis. So how do you treat in the emergency? Yeah, in the emergency department. So first you have to see whether the patient is hemodynamically stable or unstable. Hemodynamically stable means blood pressure is more than 90 over 60, like systolic blood pressure is more than 90. So if the patient's systolic blood pressure is more than 90, that means patient is hemodynamically stable. Then you can first try with some vagal maneuvers like carotid massage or Valsalva maneuver. Valsalva maneuver is like that you tighten yourself after closing the glottis. Uh, Make sure you close the anus as well when you strain. So that's called Valsalva maneuver. And also you can do the vagal massage. If it doesn't work, usually it doesn't work actually most of the time in the clinical practice. If it doesn't work, you have to give a drug called the drug of choice. What is that? IV adenosine. The drug of choice for supraventricular tachycardia is intravenous adenosine 6 milligrams. If that doesn't work, you repeat IV adenosine 12 milligrams. You can repeat it for the third time also, given the plan of management. And if it doesn't work, you can even try IV verapamil. IV verapamil. And for the hemodynamically unstable patients, you have to go for the shock, DC shock. With a very small joule, like 50 to 100 joules, you can start. Right. Then, yeah, so these are the adenosine vials. I have just displayed that. Sometimes they might show you these adenosine vials and ask you, this is how you shock the patient. This is how you place the electrodes, the sternal and apical pads from a cardiac defibrillator. Okay, what is this ECG about? Tell me what the diagnosis is. Yes, guys, you can have a go. So this is again a tachycardia. This is a tachycardia, but irregular tachycardia. Can you see RR intervals are irregular in the rhythm strip? Here, the bottom strip, RR intervals are irregular. It's a tachycardia, but with irregular RR intervals. And also, so actually, some places it's not tachycardia, some places it's brady also. So anyway, in this ECG, it's a narrow complex but irregular complex, narrow irregular complexes. And can you visualize P waves here? Can you see P waves? Here there's no P. Here there's no P here, no P here. So this is irregular, narrow complex ECG's rhythm with absence of P waves. So what are the key features? Absence of P waves, irregular RR intervals, and you should get a fibrillating baseline. Can you see fibrillating baseline here? Fibrillating can become fibrillating baseline. So this is what you call atrial fibrillation. This is atrial fibrillation, classical ECG. So they will ask how do you treat it in the emergency. So you have to tell why it is atrial fibrillation. It's irregular RR intervals, loss of P waves, and fibrillating baseline. Therefore, it's atrial fibrillation. And how do you treat? So first, you have to try with the rate control medication because if the patient is hemodynamically stable, systolic blood pressure more than 90, no APO means no pulmonary edema, no acute pulmonary edema. Then you go for rate control. You can give first oral drugs like oral metoprolol or oral digoxin. If that does not work, you can try IV digoxin to reduce the heart rate. To reduce the heart rate, we give IV digoxin, 250 micrograms. If the patient is hemodynamically unstable, of course, we have to shock the patient. The most commonly used method is DC shock with a small joule like 50 to 100 joules. You also can try amiodarone, but most commonly practiced method is giving DC shock. You can give amiodarone also. And later on, you have to anticoagulate patients with atrial fibrillation with warfarin. Right. Then the X-ray interpretation, you will be most of the time given chest X-rays. It's a very common chest X-ray which will be shown up to you all. So what is the striking abnormality you see? So I have given a separate tutorial on X-ray made easy. You have to all the possible X-ray diagnosis I have given in that. So here you can see the left lung, here you can see the right lung. What is striking abnormality? The mediastinum is normal. You can see the trachea, the bronchi, and the heart shadow. Heart is not enlarged, that's normal. And the vertebral shadow also you can see that is also normal. Then you can see the left lung, there are normal vascular markings. They are extending up to the periphery of the lung and no pleural effusion. But what about the right lung? What do you notice in the right lung? Right lung, there's a big blackish area. Can you see this, guys? Here, look, follow my curse. There's a big blackish area and then it ends up here. And here you can see a whitish, not really opaque. That's the normal lung. Normal lung vascular markings only, you can see only up to this line. Here, normal lung vascular markings you can see only up to this line. So the lung has been collapsed. Lung has been collapsed towards the mediastinum. This is the only lung tissue. This is the only lung tissue. All the other things are filled with air. So air is pushing the lung or collapsing the lung towards the mediastinum. So what is the diagnosis? This is right-sided pneumothorax. This is right-sided pneumothorax. Air in the lungs. Air in the pleural, not air in the lungs, I'm sorry. Air in the pleural space. Pressing on the, so lung is collapsed. Air in the pleural space called pneumothorax. So this is actually tension pneumothorax. That's why lung is collapsed. So what is the emergency treatment? You have to put immediately thoracostomy, needle thoracostomy. You take a needle and immediately you prick the intercostal space, the second upper intercostal space, second upper intercostal space, lateral space. I can show you that here. You can see the second upper intercostal space on the lateral aspect. Here. Second upper intercostal space on the lateral aspect. You just put a needle and air comes out. Patient will be recovered. It's called needle thoracostomy. So you have to come out with that answer first. Not IC tube insertion. Number one answer is needle thoracostomy, not chest X-ray. If you say chest X-ray, we'll be very unhappy. Immediately you do a needle thoracostomy. And then you can take time and do a chest X-ray. And after that, you with the chest X-ray, you confirm the diagnosis and then you insert a IC tube. So this is how you insert the IC tube on the lateral aspect and connect to water under seal. So look at this. It's called water under seal. Okay? Water under seal. Negative pressure. That will suck all the air into that. Then interpretation skills of various lab reports. So I have just given arterial blood gas interpretation. So this is a patient who has got pH of 7.1. The striking abnormalities I have listed down there. pH is 7.1 means acidosis. So normal pH is 7.35 to 7.45. 7.35 to 7.45. It's a normal pH. So this is definitely low side, that means acidosis. Then you have to identify whether it's metabolic acidosis or respiratory acidosis. So you have to look at the PaCO2 and you have to look at the bicarbonate level. What is the bicarbonate level? That is high actually. Normal bicarbonate level is normally 22 to 26. 22 to 26 is normal bicarbonate. Here bicarbonate level is high. Yeah, it's CO3 minus is 30. Bicarbonates are high. And the PaCO2 levels is obviously very high. So there's carbon dioxide rotation. Normal PaCO2 is below 45. Normal PaCO2 is around 45 and usually below 45. And the PaO2 is also very low. Can you see this? PaO2 is 60, so quite low, and the PaCO2 is high. So this is what you call type 2 respiratory failure. Hypoxia, hypercarbia. Hypoxia and hypercarbia. Carbon dioxide rotation. Lactate levels also little high. Normal lactates below 2. So here lactates are high because there's some acidosis going on. Bicarbonate level is on the high side. That is due to chronic compensation. Chronically, due to carbon dioxide rotation, chronically patient is compensating with increased secretion of bicarbonates from the kidneys, kidney buffer. But however, in this situation, patient is unable to compensate for it with the secretion of bicarbonate, and patient is gone into base excess. So the base excess is minus 1.6. So that is below the normal range. So base excess is normally between minus 2 to plus 2. If the base excess is more than plus 2, that means there are a lot of bases. If the base excess is minus 2, that means there's acidosis. So here patient has got acidosis, and that's due to carbon dioxide rotation. So what is the diagnosis? The arterial blood gas diagnosis is poorly compensated. Why poorly compensated? Because patient is trying to compensate by increasing the bicarbonate level, but not compensated properly. That's why patient is still acidotic. So therefore, we use the word poorly compensated. And it is respiratory acidosis. Why is that? Because there's carbon dioxide rotation. So the proper diagnosis is poorly compensated respiratory acidosis. So what is the most likely diagnosis which can cause all these problems? It's a COPD, chronic obstructive pulmonary disease with type 2 respiratory failure. So during a COPD exacerbation, you can go into type 2 respiratory failure and respiratory acidosis. So what is the immediate treatment for this type of blood gas in a COPD patient? You have to give bi-level positive ARV pressure ventilation, or what you call BiPAP. Bi-level positive ARV pressure ventilation, or what you call BiPAP. It's a non-invasive type of ventilation. You put a tight-fitting mask, BiPAP mask, or around patient's nose and mouth. BiPAP. All right. So that's the management. Okay, so these are the types of interpretation skills that they will analyze. So we'll be discussing these things in more detail as we go along our course. So these I will discuss separately for the new students. So I think that's all I have for you. So thank you for your time. I think today we discussed widely, I think more than the number of hours that we thought of discussing. We discussed the theory component for the new students, MCQ and a single base transfer format. Then we discussed the clinical component of the exam, and we discussed the OSCE format of the exam as well, right? Okay, so the live classes in this is the mock exam, the short cases mock exam class. We will do it once they announce the date of the exam. Once you start you have to first of all pay and register for the exam. Once you pay and register for the exam, then we'll be doing the mock exams as well. But before that, because I have want to give a bit of advice, because some students they come to hospitals without going through the videos. This is no point, guys. So you have to first go through the videos. You have to study that, by heart that, train yourself, and then only you should come for the true mock exam. Otherwise, what students do is they just come for the mock exam. Macam api ano me ada mock exam meka balana. Api ano ada besak balana. Api ano ada Christmas balana. Even gila hariyanne. You can't be going like that. If you go come like that, because why I'm telling this, because I know this for last how many years I have been doing ERPM plus the last more than 15, 16 years. So every time when students come to the hospital, in the hospital only they start studying the book. In the hospital, they start reading my lecture notes on system exam. That you can't do, guys. What's the point? What's the point of coming for the mock exam and the live patient examination? Live, when you come for the live patient exam, that's true patient, true exam case. Before you come for that, you must study this. You must go through the videos. You have to go study that. You have to improve your presentation skills. Then only you should come. ඒක අර මේකට ඇවිල්ලා විසක් බලන්න යනවා වගේ ගිහිල්ලා ගෙදර ගියට පස්සේ ඔක්කොම මතකයි තොරන් වල තිබිච්ච ඒවා එහෙම වැඩක් නෑ right right so I hope you all are adults you know the right thing and the wrong thing so you will be highly benefited from that because I think I'm not just boasting but you should know that you will be most benefited from an examiner not from someone just beginning to reach the career of becoming an examiner right so so I hope you guys will be benefited from our due course so thank you very much thanks for your time so I'll leave for the moment thank you
Thank you, Doctor.
thank you